Atlanta tomorrow.
All right, guys, we're gonna go ahead and get started.
And leave it connected. I just gonna pull that.
You put it on here? Okay. This is the CME statement that we have to go over. This is how you log in to get your CME credit. That's not right. Let me fix that because this must be an old thing. This is old. Let me pull up the new one for the end of the presentation because we'll just text that number and it's in the emails that I send. And then y'all don't forget, we have this flyer. What I really need you to do is that bottom right QR code. Tell us what you want to hear about. We're running out of things to talk about. So help us help you. Today, Dr. Solis is going to talk. He has talked here before about a couple of things, but he's just going to do a Airway update for 2023. Y'all know this is informal. If y'all have any questions, y'all just shoot them out to Dr. Solis or put them in the chat and I'll be following it. And I've also got the chat where it'll come up there.
Okay, cool.
So you may see it up there. It's all yours.
All right.
It's recording?
Yeah,
yes.
I wanna sit down if that's okay.
Please do.
So that's the camera back there. Okay. So
Dr. Solis messed up my PowerPoint, obviously. Here we go.
there we go. All right, so just to introduce myself, I have, some of you may know me from either previous journal clubs or from the Rural Emergency Conference. My name is Rick Solis. I'm an associate professor of emergency medicine here at the Medical College of Georgia. I'm also the medical director for the tele-ICU and tele-ED consultation service. And we're gonna basically have a very informal talk about the state of airway management in 2023 and kind of go through some updates. You may have, if you've been to rural before, seen something very similar. So what is the state of airway management in 2023? Yeah, this is it, basically. It's actually not as bad. You know, we went through the pandemic where we went through a couple of changes and a little bit of panic. But we're gonna try to kind of avoid being in this situation where everything is on fire. Conflict of interest, I have nothing to declare. I have previously been on the Dillon Technologies Advisory Board. They're the manufacturer of a video laryngoscope. I don't have any financial relationship with them other than I was on their advisory board. And that device is not part of this presentation. The most important thing I can give you is tell you that I have come up with none of this stuff. This is a phone free online access to medical education driven lecture. I have borrowed or stolen or learned all these things from people that are much smarter than me with regards to airway management. But there are some good resources out there for RSI and airway management. Rebel EM and Core EM both have tags on RSI and everything airway management related. MCRIT.org has a very good series on the laryngoscope as a murder weapon and how to manage airways in a very advanced way. OpenAirway.org is another good reference. AmyAirway.ca, Dr. George Kovacs out of California has a very, very good website with lots of good resources and what he calls an infinity edition airway management book, which basically means that it doesn't go out of date. He keeps updating it real time as opposed to coming up with edition 1, edition 2 and revising it every couple of years. And then Vortex Approach has some really good airway management stuff.
And y'all, I'll get all those resources from Dr. Solis and make sure they're on the webpage under this journal club so that you have them.
So, you know, this is probably my favorite motto out there. No one is coming, it's up to us. And, you know, one of the things when it comes to anything in emergency medicine, anything in medicine really in general, critical care, you know, especially, is call for help, right? And get help when you need help. So taking ego out of the equation and making sure that you have the right person taking care of the patient or helping you taking care of the patient. So be willing to call for help early and often. However, keep in mind that when you call for help, often there is nobody on the other end to pick up the phone, right? And so I'm here at Augusta University. I have worked at rural facilities where I'm the only person, I'm the only physician in the hospital. I'm an old medic, so I'm used to, being in the back of the truck by myself where there's really nobody to help me. So the bottom line is, yes, we want to be willing to call for help and assistance, but we also need to be prepared to take care of the patient in whatever setting they are. So sometimes it exceeds our level of comfort, but it's what's required to take care of the patient. If you don't mind, if you can put in the chat box, what do you do? Are you a nurse? Are you an ER nurse? Are you a floor nurse, ICU nurse? Are you a physician, RT?
From looking at these people, I have an RT, a doctor, Dustin Hughes, Marshall, might be Bruce Marshall, so cardiology.
Okay.
Dr. Perino, emergency medicine physician.
Beautiful.
So kind of a
Okay.
big conglomerate.
Yeah, so I'll try to kind of give everybody a little bit of taste of what we're talking about. We're gonna talk about basically 7 things. Number 1, have a plan. Number 2 is one is none. So I'm a big fan of redundancy. We're gonna change the concept of RSI, okay, and we're gonna get rid of the R no longer means rapid, it means resuscitation. You got to resuscitate the patient. So RSI is resuscitation sequence intubation. We're going to talk about the use of the bougie, video laryngoscopy, and salad, and getting rid of the yanker. Okay, so step number 1 is having a plan. Okay, so having a plan is extremely important. Having a plan A, a plan B, a plan C. So that's true for every resuscitation, but it's especially true of airway management, where things often don't go according to plan. And so I'm a big fan of developing a plan from A to Z. So I know that I'm going to have a first intervention, and I know how I'm going to plan to manage that airway initially. That may be direct laryngoscopy, it may be video laryngoscopy, it may be a standard geometry laryngoscope, it may be a hyperangulated scope. But when that attempt fails, I need to have a plan to move on to the next step. I need to have a plan B, and I need to have a plan C, I need to have a plan D, all the way to the ultimate, final plan. And what is important here is to have a shared mental model with everybody in the room. So one thing that is very important is to articulate that plan to everybody that's in the room, to your respiratory therapist, to your nurses, so that everybody has what's called a shared mental model. So at the beginning of the resuscitation, at the beginning of this intubation, we're gonna say, we're gonna take this patient's airway because they have respiratory failure. They have failed, non-invasive ventilation. My plan is to go ahead and do the regular endoscopy, if that's what you have, and using a bougie. And when that fails, my secondary plan is to change to video. When that fails, I'm gonna drop in a supraglottic airway, such as an iGel. When that fails, we're willing to, do a cricothyrotomy and cut the neck. And notice the phraseology there is not if we fail, but when we fail, because even changing that little bit of a verbiage puts us in the mindset that we are going to do this, okay? And you're going to move from one attempt to another. The most important thing to change when something happens, when you have a failed airway attempt, is to change something. It doesn't really matter what, but change something. Change the provider, change the method. So you're gonna go from, you know, a mag blade to a Miller blade, or you're gonna go from the regular laryngoscope to a video laryngoscope. Change something, change the positioning of the patient. Because if you don't change and you do the same attempt a second time, you're gonna end up with the same results. So that's very, very important. So have a plan, communicate that plan to the rest of the team, and be willing to move on, and be able to have people that, you know, put their hands on the equipment, right? So if your plan is to go from the regular endoscopy to a supraglottic airway, where is that supraglottic airway? Can you lay hands on that? Is it readily available for you to pull the trigger? And then start thinking 1 or 2 steps ahead of time. Okay, so I don't want to call for the supraglottic airway when I'm struggling to ventilate the patient. I want to have that readily available in anticipation of that failed intubation attempt. The most important thing that we can do is during the plan is pre-oxygenate. So we have got to pre-oxygenate the patient, and we have to hyperoxygenate the patient. And so our goal is to keep the patient on this part of your curve up here, on the deoxyhemoglobin dissociation curve, right? And so the deoxyhemoglobin dissociation curve looks like this. And the reason it looks like this is because the more saturated your blood, the more likely it is to hold on to oxygen. The less saturated blood, the less it's likely to hold on to oxygen. And that's a brilliant design for the body, because you want to have high levels of oxygen where you're loading that hemoglobin molecule in the bloodstream, and you're going to have very, very low levels where you're actually offloading that hemoglobin. But what that means is that you tend to stay at high levels of oxygen, high concentrations of oxygen for a long time. But once you start to drop, once you come off that cliff, you're going to drop very, very quickly. And I think we've all had that experience of, you know, we have an intubation attempt, somebody's in the background calling oxygen saturation, and it's 100, it's 100, it's 100, it's 99, 99, then it's 98. And then when you get to about 93%, it starts to drop very, very quickly. So you go from 93 to 90, and then from 90, you drop down to 80 very quickly, 70, 60. And so that drop off is very, very abrupt, with an inflection point of about 93%, okay? So that's really the lower edge of where we should be comfortable taking an intubation attempt where the patient is apneic, because from that 93%, that patient is likely to desaturate. Likewise, if you get down here in basically panic land, where the oxygen level is very low, it's going to take you a long time and a lot of effort to get it back up. So the trick is to stay at the top of this oxygenation curve. How do you do that? Well, you load up what I call all the patient's tanks with oxygen, okay? So air is mostly nitrogen, and then part oxygen, so about 80% nitrogen, about 20% oxygen, 21% oxygen. You want to get rid of all the nitrogen that you can and replace it with oxygen. So all the patient's tanks you want to replace with oxygen. So I want to make sure that I replace all the air in the alveoli with 100% oxygen. I saturate the hemoglobin molecule with 100% oxygen. So I have 100% oxygen saturation to begin with, or as close to it as possible. And then I start filling up the plasma with dissolved oxygen. However, there's really not much oxygen that can be dissolved in the plasma. If you look at the delivery of oxygen equation, please don't look at the delivery of oxygen equation because it is very complicated, and I hate teaching with formulas like this. But really what's important here is that if you look at how you deliver oxygen, the delivery of oxygen is equal to the cardiac output, right? So heart rate and stroke volume, so how fast the heart is beating and how how well it's working, what's your cardiac output, times the arterial concentration of oxygen, right? And so the arterial concentration of oxygen really depends on a couple of things. There's this constant I don't really care about, but you have the arterial saturation and the hemoglobin, right? So most of your oxygen is dissolved in hemoglobin, and only a very, very small amount is dissolved in the plasma. That's where that 0.003 comes. That's a very, very small part. The vast majority is up here, and it depends on the hemoglobin. So whenever we're talking about intubating a patient that's critical, we can't just focus on the intubation itself. We have to focus on the resuscitation of the patient and the physiologic status of the patient. What is their heart rate? What is their cardiac output? What is their blood pressure, which is related to this, cardiac output? And what is the patient's hemoglobin in addition to the arterial concentration of oxygen, what their oxygen saturation is. So if the only number that you're looking at is the pulse ox, you may have a bad day. We need to optimize all these other numbers. But ultimately, if we're trying to maximize the amount of oxygen that the patient has available to them, what I call a reservoir for a quote unquote safe apnea time. When you give medications to sedate and to paralyze, the patient's going to be apneic, their oxygen saturation is going to immediately start dropping. We need to have some money in the bank that we can withdraw and use as collateral. If you start out with very little or no money in the bank, you're also going to have a bad day. So pre-oxygenation is key. All right, and again, this is just kind of talking about that point, that cardiac output. You need to look at heart rate. You need to look at the cardiac function, stroke volume, preload and afterload. What is the patient's blood pressure? And then the delivery of oxygen really depends mostly on the hemoglobin concentration plus the pulse oximetry readings. So we'll talk about resuscitation sequence situation and how all those numbers are very, very important. We want to fill the patient's tanks with oxygen, okay? Fill the alveoli with oxygen 100% and fill the hemoglobin as close to 100% as you possibly can. This is a very important slide, and this is the airway equivalent of Maslow's hierarchy of needs. When we are taking somebody's airway, we are going to ideally give medications to facilitate that. And as we do that, our hierarchy of needs, our priorities are number one, to have a patient that is just as alive at the end of our intubation attempt or airway management attempt as when they started. Ideally, they had no physiologic compromise. So no drop in blood pressure, no drop in oxygen saturation, no drop in heart rate. Anything above this line is gravy, but it would be ideal to have a patient that had no pain, no memory, or no awareness of the procedure. So, the ideal patient would be a patient that has no awareness of the procedure, had no memory of it, and suffered no pain through it. But ultimately, that comes sometimes at a cost of having physiologic compromise and ideally not have an untoward outcome. So again, resuscitation sequence intubation is the important part, and optimizing those physiologic parameters prior to the intubation are important. So we keep getting drilled, and since I was an EMT basic, we were we got drilled with ABCs, and airway comes before breathing, and breathing comes before circulation. And so jumping at the airway and trying to intubate a patient is often something that is done because airway comes before breathing and circulation. However, all those things are intertwined, and intubating a patient that's hemodynamically compromised is suboptimal and can lead to a bad outcome and cardiac arrest. So George Kovacs came up with what he calls the rule of 90s, in which our goal when we take somebody's airway is to have a 90% first pass success rate. meaning that I'm able to secure the airway on my first pass. That is important because every attempt after the first attempt is associated with increased complications, increased mortality, increased morbidity, increased episodes of hypoxia, hypotension, and airway trauma. So we want to have a first pass success rate of about 90%. That means that you have to be prepared. That means that you have to train. And it means you have to have the right equipment to allow you to do that. And it also means that we need to make it easy on us and not have that intubation attempt with one arm behind our back. You want to do all the tricks and use all the tools that will allow you to pass that tube or secure that airway in the first place. The second part of that is you want to have that intubation attempt done within 90 seconds. And again, I'm an old school medic where we were told, 30 seconds per intubation attempt, hold your breath while you're intubating. And then if you have to take a deep breath, the patient has to breathe. All that is nonsense. The most important part is actually passing that tube in the first attempt. And so if you're at 30 seconds and your patient still has a good oxygen saturation, and you can probably pass that tube in the next 15 seconds or so, go ahead and pass that tube. But intubation attempts really should take ideally no more than 90 seconds. More importantly, though, intubation attempts have to occur with no hemodynamic instability, okay? No change in vital signs. We know that if the patient's oxygen saturation drops below 90%, they have worse outcomes. And if the patient's blood pressure drops below 90 systolic, they have worse outcomes. So we need to make sure that we pre-oxygenate that patient as much as we can, fill their tanks up with oxygen, and that if the patient is getting down to that critical 90%, we abort that intubation attempt and re-oxygenate that patient as much as we can. Earlier I said 93%, and that's because the inflection point really is at 90%. If you below 90, you're gonna obviously be hypoxic, but there is something called oxygenation or pulse ox lag, meaning that you are measuring the patient's pulse oximetry at the periphery, at the finger. That is distal to the central circulation. So if the patient's oxygenation is dropping, by the time that you are detecting that at the finger, the pulse ox reading of the central circulation is much lower than that, okay? So from the time that you stop that intubation attempt and start ventilating that patient, you're gonna continue to have a drop in oxygen before you start rebounding back. So you can't stop the intubation attempt at 90%, you really need to stop it at 93%. And there's some data that supports that. We'll take a look at that later. With regards to the plan, this is something that is a great idea. This is what's called a kit dump. Our friends in Australia, New Zealand, and Europe use these religiously, not only in the pre-hospital environment, but also in the operating room and in the emergency department. And what it is just basically a pre-printed mat that has all the equipment that you're gonna need, primary equipment and backup equipment, so that you have a visual confirmation that the equipment is there and readily available. This one has a checklist with a call, challenge, response, so that somebody can go down the list and make sure that before we have an intubation attempt, we check all these things and make sure that the patient is ready, positioned, staff is ready, you have the right IV access and medications available, intubation equipment, and then a team brief. There are a number of these available online, and they can be printed and laminated, and they are a very good, helpful adjunct so that you have a plan, you have the equipment, and it's readily available. It doesn't have to be something this complicated. This is Dr. John Hines' kit dump. He was a flight physician out of, actually he was not a flight physician, he was a pre-hospital physician, intensivist, emergency medicine doc out of Northern Ireland. And it was something as simple as taking the garbage bag that he kept to kind of gather all the equipment at the end of the resuscitation, and then outlined with a Sharpie of the equipment that he was going to need as a primary and a backup, and a very, very short call response checklist. So it doesn't take a lot of money to do this. It just takes some effort and, again, pre-planning. Next, we're going to talk about 2 is 1 and 1 is none. And again, our goal is to have a patient that has no hemodynamic compromise, right? So rule 90s, 90% first pass success within the first 90 seconds, with no hypotension, keeping the blood pressure over 90 and keeping the heart rate over, the oxygen saturation over 90. Again, we talked about the oxygen hemoglobin saturation curve, and keep in mind that some patients are going to drop faster than others. So patients that are critically ill, septic patients, patients that are morbidly obese are going to be out further in this curve or on this graph, and they're going to drop more precipitously, more rapidly. So you have to be ready for the patient to deoxygenate. We'll skip that one. So how do we do that? Okay, and I think most of us are now on board with using what's called high flow nasal cannula, the no DSAT protocol, the no DSAT protocol, and this is something that was developed by Dr. Leviton and Dr. Weingart, and has taken off in the last 10 years. And so the use of a regular nasal cannula placed on the patient at 15 liters per minute before intubation, during back valve mask ventilation, and keeping it on during the intubation attempt to extend the patient's safe apnea time is something that has been proven. Initially, we had some resistance to kind of take this on, but it has proven to be very, very beneficial. And so we're gonna start, I first start my intubation attempt or my airway management attempt by putting a nasal cannula on. And sometimes it looks silly because the patient, is gonna go immediately on BiPAP. I still put that nasal cannula on underneath. It contributes very little to leak, and it adds a lot of flow that will continue through the intubation attempt. So high flow nasal cannula under either BiPAP, a non-rebreather, or a back valve mask is going to be, a key part of airway management in 2023. Why high flow nasal cannula? And keep in mind, when I say high flow nasal cannula, and when I do this for my residents and for medics as part of a siloed course, I'm very clear that you have to be clear in what you speak. If I am talking about high flow nasal cannula, and I tell one of my respiratory therapists in my ED ICU here, hey, I need high flow nasal cannula, somebody's gonna basically wheel either an OptiFlow or a Vapotherm in the room. And that's not what I mean by this. If I'm calling a home health respiratory therapist and say, hey, Mrs. Smith needs a high flow nasal cannula, I'm gonna end up with a very, very long nasal cannula that's, a little bit thicker, so that I can support more than 6 liters of flow. What I mean by high flow nasal cannula is using a regular nasal cannula at 15 liters per minute. And yes, the nasal cannula will deliver, 15 liters and more, despite the quote unquote 6 liters per minute is the maximum that we can deliver. That's really a comfort thing, and a long-term thing. We're talking about using this as a short-term adjunct in order to oxygenate the patient. So that high flow nasal cannula is going to do 4 things besides providing a secondary source of oxygen. It irritates the patient, right? So I don't know if you've done it, but if you haven't, put a nasal cannula on your face and then turn that flow up to 15 liters per minute. It's a lot of flow. It really irritates the heck out of you. But it's the equivalent of being basically sternal rubbing the patient continuously, stimulating them to remain awake and to breathe. It creates a pharyngeal reservoir of oxygen, so it opens up and stents those pharyngeal airway tissues and fills them with 100% oxygen. And then it creates some turbulence flow that actually contributes to PEEP, and adds a little bit of pressure. And as we know, it's not only about flow and concentration, but also about pressure when it comes to oxygenating patients. So the standard approach really should be a nasal cannula underneath whatever other device you're using to pre-oxygenate that patient, either a nasal cannula, a non-rebreather mask, or a bag valve mask, or even BiPAP. So as you pre-oxygenate, allow the patient to breathe continuously for 3 minutes or 8 maximum towel breaths is usually what it's taught. However, with the nasal cannula on, we're gonna increase the nasal cannula flow to at least 15 liters, removing the mask or the bag valve mask, or leaving the nasal cannula in place, and then allowing paralysis to take place. And you're gonna leave that on until the patient has had their airway completely secured. The next step is talking about 2 is 1 and 1 is none, and that is talking about redundancy. One problem that keeps coming up, when I tell you, hey, we're gonna put the nasal cannula on the patient at 15 liters, and that's on top of the non-rebreather or bag valve mask that we're doing, is how much oxygen do you have access to, right? And so even at a tertiary care center, I only have one oxygen plug-in in the wall, right? And so when it comes to oxygen and suction, we really want to have at least dual supplies of oxygen and at least 2 suctions. And we'll talk about my 2 suctions in the future. What I often run into is, Dr. Solis, I don't work in a big academic facility. I am in the ambulance, or I am at a rural facility where I only have 1 suction on the wall if I'm lucky. And really, all of us should have access to that second oxygen, that second suction. How do we get that second oxygen, second suction? The crash cart, okay? So again, keep in mind that every intubation that we do is a resuscitation intubation, right? We're not doing elective intubations in an operating room. You need to be able to resuscitate the patient, okay? So the crash cart should be readily available, if not in the room. Actually, it should be in the room. And that's also how you get that second suction and how you get that second oxygen source, in addition to which you'll get all the crash medications that the patients are gonna need when they're gonna do what? When they crash during your intubation attempt. So you'll have the monitor available, you'll have the drugs, you'll have your suction, you'll have your backup oxygen. So again, resuscitation sequence intubation, we've alluded to this in the past, but the concept is that we need to stop focusing on rapid, okay? We are not trying to rapidly intubate somebody to prevent aspiration during an elective surgery, as anesthesia does. We are intubating somebody because this is part of a resuscitation, and these are not usually elective procedures. We can't wake them up and reschedule their level 1 trauma. So we have to be careful in who we decide to take their airway and make sure that that is actually indicated. But when we have that carefulness in mind, we know that we have to be committed to actually doing, right? And so every intubation is part of a resuscitation, and your focus should be on resuscitating, okay? So if you're trying to resuscitate, to intubate this patient with these vital signs, we're probably gonna end up with a dead patient, right? So you remember, any blood pressure less than 90 leads to worse outcomes. If you intubate this patient with a blood pressure of 60/40, that patient is gonna end up in cardiac arrest. So even though airway comes before circulation, I cannot take the airway until I fix that circulation problem, okay? So making sure that the heart rate is stable, making sure that the blood pressure is stable, giving IV fluids or preferably blood. Because IV fluids, if this is a trauma, IV fluids cannot um, carry oxygen, right? Or clot. Making sure that the oxygenation is as high as it possibly can be. Make sure that any acidosis is taken care of is important. Scott Weingart came up with the acronym of the HOP killers, the things that kill your patient during an intubation attempt. Hypotension, hypoxemia, and acidosis, right? So H for hemodynamics, O for oxygenation, and PH for metabolic acidosis. If your patient is hypotensive, give them a little bit of push dose pressure, whether it's phenylephrine, whether it's starting them on a norepinephrine infusion, and getting that blood pressure up so that you have some room to maneuver. And when the blood pressure drops, they don't arrest. Making sure that they're oxygenated above, as close to 100% as possible, ideally above 93%. Sometimes we have patients that we have to intubate that we cannot get oxygenated past that point. If that's the case, know that they're very likely to get even more hypoxemic and perhaps even arrest. And if the patient is acidotic, correct that acidosis during intubation. Once you pull the trigger in that intubation attempt, they're going to become markedly more acidotic. And we already kind of talked about this. So bottom line is the laryngoscope is not a license to kill, right? You're not 007, and it should not be a murder weapon. So make sure that as we're managing these patients' airway, you are doing no harm. Okay. Interesting. It's beyond the scope of this lecture as to the medications that you would choose, and maybe at some point in the future we might do another journal club with regards to RSI medications and pharmacology of RSI. But there are some really good articles out there. Dr. Jeff Jarvis, who's a friend of mine, also a fellow EMS physician, published this, I think 2019 is when it came out, where it is a pre-hospital study, but they implemented a clinical bundle to reduce peri-intubation and hypoxia. I think this is very applicable to what we do in the emergency department. And there are a couple of articles and editorials regarding this. Total EM did a very, very good podcast on this. Podcast number, I think, is 114, where he talked to Dr. Jarvis. And what they did is they implemented this bundle where it was a DSI bundle where the patient received ketamine prior to the RSI attempt, and then had optimization of oxygenation with patient positioning, high flow nasal cannula, usually under either a BVM or a non-rebreather mask. And then if the patients got to 93%, then they proceeded with the RSI. If they did not, they basically aborted that attempt and went to a supraglottic airway and transported the patient. That may not be applicable to what we do in the emergency department, but it was a very, very well done study. And the important part really is here's the bundle. Proper positioning, the use of a high flow nasal cannula underneath the back valve mask or a non-rebreather to facilitate pre-oxygenation, and kept on during the procedure to facilitate apneic oxygenation. Delayed paralytic administration, so administration of the sedative first to optimize their oxygenation, and an oxygenation threshold of 93%. And what I found very interesting about this is that this bundle definitely worked, and it reduced peri-intubation hypoxia from 44.2% to 3.5%. And those are fantastic numbers. However, I have to focus on something, which is what was their peri-intubation hypoxia rate before this bundle was implemented. And it was 44%. So nearly 1 out of 2 patients, nearly half of all patients actually develop peri-intubation hypoxia. And what's interesting about this is that nobody knew this. If you don't track it, if you're not looking at it, you won't know. And we always think that we're doing better than we're actually doing, right? So, be very cognizant about looking at that oxygen saturation and having somebody look at that oxygen saturation throughout the attempt and making sure that you are not getting to that hypoxic spot. So in terms of the bundle, number one, head positioning. Head positioning is extremely important. There have been some changes recently. You probably trained like I did, where we focus on quote unquote the sniffing position. We probably need to abandon that term because we don't really know what that means, okay? So yes, I understand what sniffing position is and should be. And so sniffing position really means the position in which you would sniff, right? So Bethany is sitting right in front of me. So if I offer Bethany a rose and I say, here, sniff this, she's gonna basically raise her head slightly, hyper-extending at the occiput, hyperflexing at the lower neck, right? And then her nose is forward and she's trying to maximize the size of those airways to sniff and to breathe that in and smell it, okay? Unfortunately, what we usually do when we talk about sniffing position is we hyperextend the neck all the way back, right? And so if I take a swig of milk and I go, oh my God, that's horrible, that went bad, and I say, hey, Kara, smell this, she's not going to go into the sniffing position, she's gonna do this, right? She's gonna jerk her head back and hyperextend her neck, and that is not sniffing position. So 2 things that are important about positioning is number one, don't intubate a flat patient, okay? A patient that is supine is not in the best position to be intubated, and we tend to do that out of habit. The patient should be intubated in a head-up position, what we used to call ramping for obese patients, but in reality, should be a head of the bed elevated for every patient. And so we found through studies that the best position is about a 15 to 20 degrees head of the bed elevation, okay? So we're gonna elevate the head about 20 to 20 degrees. That's gonna help us get that airway in line so that we can actually visualize through those axes and get to the airway. The other thing that it does is it allows us to oxygenate the patient better, right? When you find a patient that's severely hypoxic, they're not laying flat, they're sitting upright or maybe even forward because they're trying to get their accessory muscles to maximize their ventilation. In the supine position, you have a lot of VQ mismatch, okay? As you're more upright, you have less VQ mismatch. And so we really should intubate these patients or even ventilate the patients before your intubation attempt in a head up elevation about 15 to 20 degrees. Next, we talk about flex tension, where we already talked about the sniffing position really means flexing at the cervicothoracic junction and extending at the occiput. And that flex tension will get that head in a position where the face is parallel to the ceiling, or the floor, and the external auditory canal is above the level of the sternal line, okay? Those are really the important things. 15 degrees to 20 degrees head of the bed elevation, flex tension of the neck, and then the ear canal above the line of the sternum, above the sternal line, okay? So this is incorrect. This is a better position down here. And this has been studied and has been shown to be very helpful in improving your first pass success, okay? The second part of the bundle was obviously, the use of delayed sequence intubation. That's beyond the scope of this lecture, but it was very helpful in this bundle. The next is using the bougie. Okay, I don't know how many of you guys are using a bougie primarily or have it as a backup, but the bougie is really becoming the stylet of the 21st century. I'm old enough that when I was trained as a paramedic, we were trained by anesthesiologists who told us you don't use a stylet unless you absolutely need to use a stylet because it can cause trauma and you really don't need it if you know what you're doing. And our first pass success rates were absolutely horrible. And then we started using stylets on every single intubation, and guess what? Our intubation rate successes went up. The bougie is the same. It is the stylet of the 21st century, and first pass success using a bougie first approach in which you use the bougie every single time has been shown to be superior. About 10 years ago, I started using a bougie. And one of the reasons I started using the bougie on every intubation was because I wanted to learn how to use the bougie. It's very hard to rescue yourself with something that you are not facile at and you don't use every single day. And so you have a bougie in your airway kit as a backup, and you're only going to use it on those situations that you have already failed or you have difficulty with, and you've never picked up a bougie before, or you've only picked it up once or twice before, you're probably not going to be successful with the bougie. So 10 years ago, I decided, you know what, I need to get good with the bougie. Let's go ahead and start using it every intubation, every single time. And then once I feel comfortable, I can go back to my normal intubation with a stylet. And I never did. And the reason I never did is because I found that it was much easier. And the data backs it up. Whether using what we call a naked bougie technique or a preloaded bougie with a Kiwi or Ducanto grip, it still requires a little bit of practice. So you do need to practice this on either routine airways or on the mannequin several times before you start, pulling the trigger on real patients. But using the bougie every single time has been shown to be helpful, and it's probably the way to go. The bougie is not without its problems, though. And so another thing that I really harp on is having what we call immediate action drills. You need to be prepared for failure. What I mean by that is you need to train for failure, be prepared for failure, know where your failure points are for every device that you use, and be prepared to deal with them. The bougie often fails when you pass the bougie without difficulty, but the tube will not pass. It gets to the vocal cords and it just will not go through. And that happens because that leading edge of the ET tube on the right side gets hung on that right originally. And so I know now that if I'm passing the bougie and my tube won't go through, what I don't do is I don't try to force it through, because that's going to create some trauma and then have a bad outcome. What I need to do is I need to disengage, stop pushing, bring the tube back slightly, and rotate the tube on the bougie counterclockwise 90 degrees. And that brings that leading edge of the tube to the top of the airway where the glottic opening is actually on. And then the bevel itself will work as a ramp and actually get over that lower glottic opening and feed much more easily. But you have to practice this. You have to practice these immediate action drills. As I said, there are a number of studies that show that bougie-assisted intubation is much more effective than the traditional endotracheal tube and stylet method on first pass success. And so that goes back to that rule of 90s. If I want to have a 90% success rate, I'm going to cheat. I want to do every single procedure that I can, or every single method that's going to give me an edge. And so if positioning gives me a 1 to 2% improvement in fast pass success, and using the bougie gives me a 1 to 2% improvement in first pass success, and using video is going to give me a 1 to 2% improvement in first pass success, if I add those all up, pretty soon my first pass success goes up by 10%, and have significant improvement in my results. This is the latest study, and this was taken from Rebel EM, but you can see that first pass success on patients that had at least one difficult airway characteristic went from 82% using the ET tube and stylet method to 96% using the bougie method. In all patients, the difference was between 87% and 98%. So significant improvements. It does take somewhat longer, but not significantly enough. ET tube attempt duration was 36 seconds during using the ET tube and stylet method versus 38 seconds using the bougie. But again, this requires some preparation and some training before you do that.
And before he goes on, if any of y'all do not have bougies, please let us know if your facility doesn't have them, so we can work on getting y'all some.
Next, we're going to talk about video. I don't know how many of you have video available. Video has changed airway management for the better and forever. And so there is some talk that video should be the only way that you manage these airways. I'm an old medic and I realize the realities of equipment are what they are. And so my take is that video is great to have, and I use video every single time I have it. But again, just like when, no one is coming to help you when you call for help, when you need the video, you won't have video available. And so you need to be proficient with regular standard airway management. And video is not all the same. You can have standard geometry video, such as the CMAX system, for example, that looks just like a regular Macintosh laryngoscope, but gives you the ability to also have the camera. And this is my preferred method because I can use this as a regular Mac. I can do direct visualization. I can develop those skills and practice them so they don't go extinct. But if I need to use the camera, I can just turn my head, look at the screen, and I basically have gone from a direct laryngoscope method to a video laryngoscope method on the same attempt. Hyperangulated devices such as the glide scope, VL, or such as the CMAC D-blade system do have a slight advantage. The data shows that you can probably intubate about 90% of patients with standard laryngoscope and have about a 10% failure rate at the most. If you convert to standard geometry video laryngoscopy, you get to about 99%. That 1% is the 1% where hyperangulated blades come in. And so there is an advantage to hyperangulated blades, but it is a completely different technique that you also need to learn. And you learn that kind of at the detriment of the standard geometry laryngoscopes. Here we have an example of the King Vision, which is a channeled hyperangulated device, which is also a pretty good device. And so the data is that video is great if you have it, but ideally you have a standard geometry video so you don't lose those direct laryngoscopy skills. The technique is different though, and so if you're doing using a hyperangulated video laryngoscope, you need to make sure that you have the right view, okay? And so the most common error that we make when we're using a hyperangulated video laryngoscope is that we have too great of a view. We tend to want to see this view where you see the huge vocal cords in all their splendor. If you try to pass a tube here, it's going to go posterior and go into the esophagus every single time, and you're going to be playing ping pong with the esophagus. The best view using a video laryngoscope is a 50% view where you have 50% of the glottis. So I have 50% of the glottic opening visible in the top 50% of the screen. So the bottom of the screen is basically empty of glottis, and I have half of the glottis in the top 50% of the screen. If you have that positioning, that tube is going to go in every single time. And so another immediate action drill is if you're seeing this and you pass the tube and it goes into the esophagus, don't just pull it back and push it again. Pull it back, withdraw your laryngoscope slightly and lift, and then when you get this shortened view, the tube will go in every single time. Okay. Keep in mind that fluids are the enemy of video laryngoscopy. So stay high, stay back, and lead with suction. And we're going to talk about salad to end with. Before we talk salad, we're going to talk about yanking the yanker, and this means using the right equipment and having the right equipment. We have been using the yanker catheter since 1907. It was developed by Dr. Charles Yanker, an ENT surgeon who developed it to aspirate blood and debris from a surgical bed of a tonsillectomy without disrupting the clot. It's a very delicate instrument with a very small hole and a bulbous tip to not create trauma. It's not a very good device to decontaminate a contaminated airway. So in the past, we've done things like, put together a suction as you go ET tube, so you can suction as you go, and then pass the tube in patients that had massive hemorrhage from esophageal varices, for example, or lots of secretions in the airway. We have better devices now. Again, Dr. Ducanto developed the Ducanto catheter. This is a much better suction device with a larger bore. And really, that's the right tool for decontamination. We cannot replace every yanker with a Ducanto because they're more expensive, but you should have at least one or two of these readily available. So if you have a truly contaminated airway, you can actually decontaminate the airway and not struggle with a device that wasn't developed for that. Another option would be the big yank suction system. Again, I have no financial relationship, but this one has a large bore that you can actually suck a kernel of corn through the end of this big yank, and it's able to decontaminate largely contaminated airways. Again, preparation is key. This is a suction and airway decontamination kit that I put together in a large Ziploc bag, and it's just a laminated card with things that you might want in there. A couple of Ducanto catheters, a big yank system, meconium aspirator, and a McGill forceps, adult and pediatric, so that you always know where your equipment is to decontaminate the airway if the airway is contaminated. The last thing is probably my favorite thing, which is starting with SALAD. SALAD stands for suction-assisted laryngoscopic airway decontamination. We're running out of time, so I probably won't have time to show the videos.
We can put them on the website.
Yeah, but we'll go ahead and put these on the website. But this is another concept, by Dr. Jim Ducanto, who's an airway samurai. He's an anesthesiologist from Wisconsin who has done a lot of advancements in airway management. And the concept is that regardless of what your method of airway management, whether it's direct laryngoscopy, video laryngoscopy, supraglottic airways, you are going to start out by decontaminating the airway. So you're going to lead with the suction. The suction always goes in before the laryngoscope and leads the laryngoscope, so that you're decontaminating as you go, and you are using that almost like a snowplow, clearing the way for the video laryngoscope or your standard laryngoscope so it doesn't get contaminated, at the same time decontaminating the airway. If you get into an airway that has too much contamination, you can actually park that suction catheter in the esophagus on the left side of the laryngoscope, leave it there. It'll continuously clear that airway as you are able to pass finish your intubation attempt. And we'll put this on the website so that you can actually watch those videos as we're running out a little bit of the time. The beauty of SALAD is it can be done with pretty much any airway method, whether it's direct laryngoscopy, video laryngoscopy, hyperangulated, standard geometry, or even supraglottic airway passage. And that's basically all of it. I'll leave you with two bonus things. One thing is the use of the vent as a back. What Scott Weingart terms VAPOX. And as we know, vac valve mask ventilation is a skill that we probably need to developed more than we actually have. It's a very, very important procedure that it's sometimes hard to master. And often, at least in the pre-hospital environment, we kind of relegate this to the least experienced person in the room. In the hospital, we have respiratory therapists who are very, very well versed with this. But at least in pre-hospital environment, we just kind of like, hey, who's the youngest firefighter in the room? Here, you bag. This really needs to be done by the most experienced person in the room. It is a very technical procedure, and it's really a two-part procedure. It's squeezing the bag, which is ironically very easy to do. You can actually, grab the administrator walking down the hallway and say, hey, come squeeze the bag, and they should be able to do that. But it's a procedure that we screw up the most, right? We often bag too fast, too much pressure, and to a higher volume. The difficult part of the skill is actually keeping the seal, right? And so two-person bagging probably really should be the rule rather than the exception, and or outsourcing the mask seal to a device that doesn't need a mask seal, such as a supraglottic airway, like an AirQ or an iGel. Supraglottic airway or LMA. You should also be able to outsource the bagging, okay? And so, if we screw up the bagging by bagging too much, too fast, and too much volume, too much pressure, too high a rate, it would be nice if we had a device that automatically set your volumes, your pressures, and your flows so that you wouldn't screw them up. And I think we do have that. It's called a ventilator. Ironically, we don't use the ventilator in these patients, and we tend to, shortchange ourselves by using the back valve mask. And you can use the vent in this setting by setting the respiratory rate from 6 to 8, setting our pressure support of 10 with a PEEP of 5, and titrating up with an FiO2 of 100. And then with an inspiratory time of 2 seconds, you can basically hook that up to the mask and concentrate on your mask seal while the machine is delivering the flow, okay? We have this blog about using the back valve mask in these patients or using the ventilator in these patients because we're used to taking the patient off of the ventilator as immediately whenever they crash. And so we kind of translate that into you don't ever put a critical patient in the ventilator, and that's not the case at all, right? We take the patient off the vent to get rid of any potential equipment failures. But if there is no equipment failure, we can actually, cognitively offload the bagging, concentrate on the mask seal, and then let the machine deliver those ventilations. And I think I'll leave the rest for the next journal club. So in conclusion, have a plan, have a backup plan. 2 is 1, 1 is done. Remember that every intubation is a resuscitation. So resuscitate the patient, oxygenate them, make sure that they have a good hemoglobin level. If they need to be transfused, transfuse them. If they need pressure support, support their blood pressure so they don't get hypotensive. Use the bougie every single time for improved first pass success. Video is great if you have it. If you do have it, a standard geometry laryngoscope allows you to continue to develop your laryngoscopic skills and not lose them. Whenever all you have available is a regular laryngoscope, get rid of that yanker, or at least have a Ducanto or better suction catheter available for a truly contaminated airway. And don't forget to look at those videos on salad, and always start with salad. Any questions?
I'm gonna flip this over to the CME for y'all. I don't know what happened there, but this has the phone number where you text. It'll come up. It's coming. There we go. So text 7594 to that number. And for those of you that come pretty regularly, what I do is I have that number saved in my phone as CME. That way I don't have to remember it, and then I can just text the numbers. But if y'all don't have any questions, I haven't seen any come across yet. This recording will be available. I know we've had a couple of people reach out because they had people that couldn't watch today at noon. Remember, tell your coworkers that they can get the CME for 5 days. So as long as they watch it before Wednesday, they can claim the CME still. Any questions? I think that's just. All right, guys, well, y'all have a good Memorial Day weekend. Be safe, and we will see y'all in a month.